Welcome to our update on some transplant issues, especially including the new liver and kidney organ allocation policies. My name is Brian Shepard. I'm the CEO of the United Network for Organ Sharing, and I have with me Dr. Matt Cooper, a kidney surgeon at Georgetown, who is the president of the board of directors of UNOS. And he and I are going to give a quick briefing on some transplant issues, and then entertain any questions that that you might have. So if we go to the next slide, please. So what we're going to talk about is those two new policies, some performance during the pandemic, and then as I said, we'll get to questions. So you can submit those at any time during the presentation. You don't have to wait until the question period to type those in. So feel free to go ahead and do that as we're presenting. Go to the next slide. So the United Network for Organ Sharing is a nonprofit in Virginia that holds a contract with HRSA to do the matching of deceased donor organs for transplantation. We have held that contract for more than 30 years. It's been renewed multiple times. It's been competed multiple times, but we've won those renewals, and we've been doing this work for a long time now. We match organs for every deceased donor in the United States as those become available, as organ procurement organizations recover organs from those donors. They use our computer system to match those organs with candidates all over the country who are waiting for organ transplants. We do this work by using the donation and transplant community to set policies and to make decisions. We have more volunteers than we have paid staff, and those volunteers come from the professional transplant community, doctors and other healthcare professionals. They include organ procurement professionals, and they include patients, donor family members, folks who have received transplants, folks who are waiting for transplants, who all participate in committees that do the policy making in order to make these kind of decisions to provide equity to patients across the country. So go to the next slide, please. The United States organ donation and transplant system is the largest and highest performing in the world. Last year was our 8th consecutive year of growth in deceased donor transplants, even with the COVID pandemic. Go to the next slide, please. Take a second to talk about COVID. That's just the some of the data for last year. It's actually the 10th year in a row for the number of donors and the increasing, and the 8th year in a row of the number of transplants increasing. Go to the next slide. This is what transplants looked like week by week over the last couple of years. You can see a pretty substantial drop there in March and April of 2020. And we all remember what those first days of this pandemic were like. Our sector of healthcare scrambled just like every other sector of healthcare to find PPE, to find testing availability, to understand the virus and the illness it caused and exactly how that was affecting patients. But you can also see here that the rebound was swift and really complete, that we got back to being not only on pace, but above the pace for prior years, and set an all-time record for number of transplants in a year last year, even with that drop. If you look at this same graph for any other country in the world, you will see a much deeper drop and a much wider drop, a much longer time before things turned around. And it's a tribute to the resilience of the folks in the field, the folks at the hospitals and the organ procurement organizations who are out there doing this work and not letting COVID get in the way, and really being determined to save every life that was possible. So let's talk a little bit about how these policies have changed, and then I'll let Matt talk about some of the results. So go to the next slide. We made some significant changes in in the area in which we look for a patient. So the fundamental way in which we rank patients based on their clinical urgency wasn't really changed. What we've changed across the organs in the last couple of years is where we look to see who the sickest candidate is or the most urgent candidate. And we went from an area that was based on donor service areas, and you see an example of some of those in Texas there. Donor service areas are the areas assigned to an OPO to work with the hospitals in that area to recover organ donors for transplant. And as when the system was founded, those were really then used to also prefer local meaning within that organ procurement organization's area, prefer those candidates for transplant first. As you can see in the Texas example, while those may be operationally useful to determine which OPO should do the recovery, there's not really a lot of rhyme or reason as to why we should prefer a candidate, say a candidate recovered in Dallas, anywhere in the green, but not in the blue or the purple. And so what we've moved to is a circle-based system where in all the organs, the circles are different sizes, but in all the organs, rather than any artificial line on the ground, we look to a consistent circle around the donor hospital and look for the most urgent candidate anywhere within that circle. Go to the next slide. So we developed these policies through a consensus process, a community-driven process, and a data-driven process. I mentioned the many professionals, donor family members, and patients on our committees. We put those proposals out for public comment. We use data to model those policies, and we continue to watch the performance of those policies after their implementation and make sure they're having the effect that we expect them to. And I'm going to turn it over at this point on the next slide to Dr. Cooper, who's going to talk about the early results of these two, I think, most interesting, most talked about policies, the liver circles and the kidney circles.
Brian, thanks very much. Again, my sincere appreciation to everyone taking time out of what I'm certain is an already busy day to hear about the donation and transplant system in the United States, and with which all of us who participate as the OPTN and as UNOS are very proud of. As mentioned, I'm a transplant surgeon crosstown at Georgetown. I've been involved with UNOS for almost 20 years and incredibly proud to be the current president of the board of directors. I'm going to tell you a little bit about some of the initial results, recognizing that these are certainly some early data, particularly for the new kidney allocation policy. As you can see on this timeline, carving out 2020 as a memorable year for sure, you can still appreciate that during this period of time, the data will demonstrate that we were successful in rolling out a liver allocation policy and a kidney allocation policy, which now looks at distance from donor hospitals. Next slide will begin to show some of those results. It's interesting, besides geography, we also have gotten very comfortable at geometry, namely circles, and even things like maritime terminology when you think about nautical miles, which is essentially just a straight distance and not sort of following travel patterns and such. But this is exactly purposeful in so much as the new allocation policies are designed to assure that we are getting the right organ to the right patient at the right time. We use that expression a lot, and it's not to be minimized, and it's something which we place incredible value in, is assuring that we are recognizing organ transplants as a valuable critical resource and making sure that we are finding a way to get the organs to the people that will need them the most. And if we look at, again, some of the early data, appreciating some of the successes here, I always like to start with numbers. And you can already see that in the short period of time of the kidney allocation policy and about a little over a year of the liver allocation policy, that overall the numbers of kidney and liver transplants increased despite the pandemic. That is an asterisk, but one with which, again, as Brian said, I consider it an incredible success story. But the number of deceased donor liver and kidney transplants increased not only overall, but importantly, in an effort to ensure equity and assure access. They particularly increased in our Black, Hispanic, and Asian waitlisted kidney patients to more reflect the percentage of those same populations waiting for an organ. Also importantly, pediatric kidney and liver waitlisted patients received more opportunities for transplants. And as mentioned, based upon priority and based upon how the allocation system was designed, beyond the circle-based system, prioritization for those that need them the most, those were exactly the recipients that received those organs. There was a concern from others, and certainly part of the evaluative process once putting a policy out was we needed to look at the data, that with broader sharing that would result in increased ischemia times or increased time that it would take for the organ to be transplanted. And in fact, the data did not demonstrate that. Only about 12 minutes of increased time for livers and about 2 hours for deceased donor kidneys, which clinically is really inconsequential. The numbers of liver transplants that are occurring between 150 and 500 nautical miles of the donor hospital increased, which again was expected, but importantly, those that occur over 500 miles actually decreased, meaning organs weren't crossing in the air to get from one side of the country to the other if the utility piece of our equation in assuring that no organ was wasted meant that that organ should stay closer than flying several time zones away. And so, again, these were things that we had modeled and had assured the transplant community and had assured the public that this was what we expected to see, and the data has demonstrated that. Next slide, please. A friend of ours and our current UNOS board vice president, Dr. Jerry McCauley from Philadelphia, I think stated this very well, and when he highlighted the fact that in the prioritization for kidney transplant based upon longer dialysis time meant that, again, kidneys were being allocated to those that needed them the most, the sickest patients. And he said the new kidney allocation policy has directly improved equitable access to transplants, especially for patients of color. Additionally, receiving a kidney now demands is more dependent upon a patient's medical need rather than their geographic location, which is, of course, something that has to happen. We can't think that because where someone resides or what their zip code is, that they have a greater access or a lesser access for the gift of life. He says, we've worked together as a community for decades to increase equity in the national transplant system. And from our early efforts to this new policy, I'm proud that we have dramatically increased equitable access to life-saving transplants for more waitlisted patients. And Jerry's words ring very true. And again, something that I think we're all incredibly proud that these new allocation policies have achieved the goal with which we had intended they might. Next slide, please. And so when we, again, look at those, the data and the key takeaways, overall, the numbers of deceased donor kidney and livers increased in terms of volumes of transplants, but particularly for Black, Hispanic, and Asian patients, pediatric patients, and those that were most in need, the sickest patients. Travel increased slightly to get to those sickest patients. We found a way to make sure that packaging and transportation didn't prevent the allocation to those patients that needed them the most. For livers, the distance 250 to 500 travel time increased, but travel over 500 miles decreased. So we weren't sending livers that potentially would be non-transplantable based upon too great a cold ischemic time. And the proportion of kidneys traveling less than 250 nautical miles increased slightly. Pediatric kidney transplants increased by 47%, and adolescent liver transplants increased by 68%, again, reflecting an access to pediatric donors who are primarily assigned to pediatric or adolescent liver recipients. So again, the system very thoughtful in addressing a need, assuring that access to transplanted organs for waitlisted patients was a priority, making sure they were getting to the sickest patients a priority, and now the data that is being analyzed reflecting that, in fact, what was predicted has resulted in a success. Next story, please. Next slide, please. Brian, I think this is for you, my friend.
All right. I'll just, if we go on to the next slide, I want to mention that these are obviously some of our highest profile equity projects over the last couple of years, but really all of the policy work we do, all of the changes to the allocation system are about equity. They're about making sure that everybody who is listed for an organ transplant has an equitable chance to to get a transplant, and that the priorities are really based only on clinical factors. We prefer candidates because of their medical urgency. Sometimes we prefer them intentionally because of their difficulty in finding a match, because they're highly sensitized, and there's not many organs that would be a successful transplant for that person. We prefer pediatric candidates in some form or other across all of our organ transplant policies, but we're committed to making sure there aren't any unintentional preferences or differences in access to transplant, based on other factors. And so just to highlight a few of those things, the Kidney and Minority Affairs Committees are currently examining a calculation, it's an estimate of kidney function called eGFR, that is calculated by each hospital who lists a candidate. And in some of those formulas, those hospitals use a race-based factor, and that we're examining whether that's an appropriate thing to leave in the system. We have a equity dashboard that you can look up at any time and see sort of how the policies are performing. You can see what causes the biggest difference in access to transplant based on any number of factors. And you can, in fact, as it turns out, you can see that that non-medical factors rarely provide much difference in access to transplant at all. And we think that will be especially true as the effects of these geography policies really start to be seen. We're also looking at how access to the waiting list is affected by non-clinical factors. We don't list the candidates. We don't determine whether they are candidates for transplant at UNOS. Their treating hospitals make those decisions. But we suspect that, like in all healthcare in the United States, not everyone has the same access to primary care, to specialty care, and presumably also to transplant care. And to see, we know that once people are on our waiting list, the policies provide them with a very high level of equity, but we're also looking into what the differences are or might be in getting to that wait list. And if we can identify and understand those differences, we can determine whether there's anything we can influence in that area, even though it's beyond our direct authority. We're also doing research to see what, if any, differences came out of COVID, and we are always increasing our patient education to make sure that patients have the skills and the information to be their own advocates and to push for their own equity and to understand the system that they are a part of, and that equity really is the fundamental purpose of NOTA's creation of the organ procurement and transplant network. The reason that Congress created a national system from the many regional systems that existed in the 80s. And so that's the work of our organization, and that's the work we do every day. So go to the next slide. At this point, we're happy to take any questions that anybody has, and we'll see what we can do to answer them.
All right, thank you for that update. We do have a couple of questions that have come in, and as a reminder, there is a questions pane in the control panel that you can type questions in that I'll be happy to ask Dr. Cooper and Brian. The first question we have, Dr. Cooper, why do the differences in donation rates have to be fixed at the national level? Why can't every area receive its own donated organs?
Well, thanks for the question, and Tina, thanks for organizing the Q&A period. So as great lead-in following sort of Brian's comments about the organ procurement transplantation network that was a result of the National Organ Transplant Act and other additional sort of rules and policies based upon the final rule, and our really demands that we get to the right organ, to the right patient at the right time means that we have a national system to assure that regardless of where people live, that they both have an access to donated organs and have access to that organ should it be a distance away. And so we really need to be able to collaborate on a national basis in order to assure that we are achieving those goals. We do have to, again, appreciate that we don't want to maximize equity at the expense of efficiency, so that we, again, don't want to be transplanting organs, across multiple time zones if, in fact, it is best that an organ remains sort of closer to a donor hospital. And so that is, part of the current allocation systems. And we also want to make sure that we don't affect the quality of that organ too. So primarily the obligation is to assure that the national system assures that the people that need the organs most can get them regardless of where the organ is donated. But we always look to, again, prioritize what we believe as a transplant and as an overall community as prioritization, which would include particularly children that we highlighted in some of these slides, and the folks that need them the most, but also other characteristics we call people that are highly sensitized, or people that have a difficulty sort of finding a match. It's one of the few times I would use the word match. But again, the likelihood of them finding that opportunity means that we want to have them at the top of a national allocation-based system, so that if they were to find that sort of needle in a haystack, that it's available to them. It would be much limited if we were only continuing to allocate on a regional basis. And that's why, all of these new allocation schemes are designed to make sure that we are maximizing benefits and ensuring efficacy and efficiency throughout.
Great, thank you. Brian, what does monitoring these policies mean, and who oversees your work to make sure the data isn't skewed to support these policies?
Sure. We prepare statistical analyses of the outcomes of these policies for the committees that drafted the proposals, and for the board of directors who approved them, and they routinely meet and review and discuss the outcomes and determine whether those outcomes are in line with what our expectations were. The policies are modeled before they are approved and implemented, and so we check back to see whether those are consistent with what we expected the policies to do, and we publish reports of those policies. You can read the same reports that the committees and the board can read on the OPTN website. It's optn.transplant.hrsa.gov. But if you would like a copy of those reports, you can even put that in the chat or the question box, and we'll make sure to get you a copy of the most recent outcome reports for liver and kidney. Those are publicly available, and if folks even want to check the math behind the reports, all the data that we collect is publicly available. The public versions of the data are blinded and protect patient information, but researchers routinely use that database to make their own conclusions about the effectiveness of the policies, and to make suggestions to us about policy changes that we should make in the future. That data is also available to media and to policymakers, and again, we can help facilitate that if you're interested in some of the raw data. The file is obviously very, very large, and so there are a lot of do-it-yourself reports on the OPTN website. But if you have a specific question, we're also happy to help answer that.
Great, thank you for that. And Dr. Cooper, I have a question for you. In addition to the EGFR race correction, I have heard of a race-based factor in determining graft failure in kidney transplants that automatically assumes organs from Black donors are more likely to fail. Is UNOS examining this in its equity work as well?
That's a great question, Jacqueline. Thank you for that. So I'll say this. I think specifically what's being referred to is less of a race-based concern, but of a genetic concern, APOL1, which is something with which the donation and transplant community across the board has been very interested in. Commonly found in African American individuals, quite frankly, as a protection against sleeping sickness. But there has been some data that demonstrates a donor of two positive alleles for this APOL1 potentially has an increased risk of developing kidney disease as they get older compared to an individual who does not have these alleles, and the recipient of an organ from that same person potentially as well. So this honestly isn't specifically something that UNOS per se is looking at, but it is something that the transplant community in support of UNOS and the individuals who make up the body of UNOS, work collaboratively together to again determine if there is something that is found in this research that potentially it would be something that could be translated over into either donation or allocation policy. But that's a very hot topic. It is very I think appropriate. And it's something that UNOS has their eyes on. But to be honest, this isn't something specifically UNOS is looking at, but its members have made UNOS aware that this is happening, and perhaps down the line this would be something that would be applicable to further allocation practices and policies.
Thank you, Dr. Cooper. And Brian, I have a question for you. Can you please share the overall national data on organ discard rates and organ transport cost?
Sure, I can sort of summarize that. And again, a lot of this data is available. You can find that on the website if you want to get really specific about a certain part of the country or a specific organ. Discard rates haven't meaningfully changed during the implementation of the circle policies. My expectation is actually that the discard rates will probably go down as all areas of the country really are on a level playing field as far as what type of organs are available for their candidates. We also have a number of other policy projects underway attempting to really drive up utilization rates, because it is important that we make sure that a transplant hospital is using all of the organs that are available for transplant and making the best use of all of these gifts to support the entire wait list. There's been a lot of attention recently on how to find more organs and whether OPOs are doing enough to recover enough organs. But close to 20% of all the kidneys that are recovered for transplant are not actually transplanted by any transplant hospital. So there's a real opportunity there to make sure that we're serving all the patients. UNOS does not have data on hospital costs, and so I can't speak directly to that. Certainly there are going to be some increases in travel costs as distances go up. I don't know that those, I think that the percentage that's been reported by a handful of centers, although I think it's the centers that had the highest increases. I think those even those numbers as an increase in transplant are still relatively small compared to the cost of an organ transplant. But it's certainly a factor, and we want to be as efficient as possible, as Matt said in an answer to an earlier question.
Thank you, Brian. And I have another question here. Is it true that COVID is creating a larger demand for organs? How can you say that there's no new demand for organs because of the Delta variant?
Good question. So I would say there's always a need for more organs. We always recognize that the challenge, quite frankly, that keeps me up at night is the supply and the demand problem for organs for transplant. So there's always an opportunity to think about more greater ways in which we can increase the number of potential donors. But specifically related to COVID, and the effects of COVID resulting in organ failure and need for transplantation. Only in the lung population, as you can imagine, the epidemiology of the virus causing lung injury primarily. There have been, and we've only recently started to collect that data. There's less than 150 individuals who have received a lung transplant for reasons related to specifically to COVID. The opposite is actually true for other organs. For instance, kidney, where I spend most of my time, the number of registrations is down over 2020. It has since recovered to normal pre-pandemic levels that we follow on a regular basis. But some of that was because of, again, potential access, which we've talked a lot about, not just access to organs, but access to waiting lists, which is something that continues to be, I think, not only a transplant issue, but also a sort of a national public health issue, has actually decreased because, again, the urgency for kidney transplant based on dialysis, many folks who were just either starting dialysis or didn't have a living donor, there wasn't a great need to present during the pandemic to get listed, knowing when they did eventually come forward, they would regain waiting time based upon time on dialysis. There has been, I think not surprisingly, an increase in for folks that spent more time sort of isolated from friends and loved ones, an increase in substance abuse overall, and so there has been an increase in liver transplants secondary to alcohol-related diagnoses. That increase is about, I think it's about 5 or 6%. But overall, not a significant percentage that I can say is specifically related to the virus. They're related to the issues surrounding the virus. But overall, the numbers of transplants specifically related to the virus has not shown an uptick. What I think is critically important to demonstrate the success of transplant, and I get very probably overexcited of this. When you looked at the data of when the pandemic was at its peak, the picture that Brian showed earlier, and because of that, we were still uncertain about whether or not transplant was the safe thing to do from a transplant center perspective. When transplant rates decreased, the deaths on the waiting list increased. And so there was a direct correlation that said transplant works, transplant saves lives. And when we were able, as a donation and transplant community, to get those transplants back or to get them to places where they could be utilized because of, unfortunately, ICUs that were unable to accommodate transplant recipients, those rates of death on the wait list returned back to the levels pre-transplant. And so that, to me, that was just a sort of a beautiful life experiment of transplant saves lives, and the fact that we had to do everything we needed to do to make sure that transplants continued even and around the pandemic, and work collaboratively to make that happen.
Thank you for taking that question. I don't have any other questions, but I do want to point that there is some information in the chat box there that will, it's a link to the work that the EGFR work group has out for public comment now through just 2 more days until September 30th. But that is the end of the question and answers that we have here.
Well, great. Thanks, everybody, for attending today. We're glad to have a chance to provide you an update, and we're happy to answer any follow-up questions or provide any data or information about any other part of our donation and transplant policymaking at any time. So please feel free to reach out to us in the future. And again, thank you for your attention today.